So, what kind of symptoms do people present with when they have something wrong with their rectum or their anus? Probably the most common is pain. Second most common might be itching. Third most common might be bleeding. But rectal pain is a common presentation. Now, when someone comes in and says they have pain in their rectum, the number one thing you have to realize up front is that this is not easy for them to talk about. It's not easy for some of us to talk about or to listen to. And so their history initially may be quite unclear. And this will require you to use all the skills in your interviewing toolbox to facilitate, make them feel comfortable, and facilitate a story. An examination for someone who presents with rectal pain is essential. You gotta look at it. You gotta see it. If you just start guessing and trying medicines, you're gonna miss the diagnosis. You gotta look at it. So how do we go about doing this? Well, one way is to lay the patient on their side. Let's say they're laying on their left side, and you raise their right, you flex their hip to the right, and then raise their right buttocks out of the way so you can view the anal verge. In my practice, I started there with all female patients who came in complaining of rectal pain. I'd then just put on a gown, lay down, roll over on their left side, and then examine them from that perspective. In all men patients who complained of rectal pain, I examined them exactly like I did the rectal examination, which was to have them standing at the bottom of the table and lay their chest over on the table. That way I could sit on my stool and get a really clear view of what I was looking at. You'll have to just sort of try this out in your clinical situations and see what works best for you. And then what you're doing is you're just looking to see what you see. And then you'll, if they're not in too much pain, do a rectal examination with your forefinger. That's really all there is to a rectal examination, unless you need to use an anoscope. An anoscope is a small instrument about this long that you can slide into the anal canal, and by virtue of watching as you're putting it in and watching as you bring it out, you can see the anal mucosa. Okay, so what happens, excuse me, what happens if a patient comes in complaining of rectal pain, but the examination is completely normal? Turns out that this is a relatively common problem. If the pain is recurrent and difficult to localize, it seems to be right in the anus, you're probably dealing with some muscle spasm syndrome, and there are two of them. There are two muscle spasm syndromes that present as rectal pain. One's called proctalgia fugax, and one's called levator ani syndrome. These were redefined. They were sort of one syndrome until the Rome III conference, and they've been redefined. So now you distinguish the two in the following way. Levator ani syndrome is a syndrome of the levator ani muscle spasming, and the pain is coming either from the actual spasm of the muscle or the squeezing of the rectum. as the levator ani surrounds the rectum, it can squeeze the rectum. And we know that there are receptors in the GI tract that respond to squeezing and stretch. Levator ani syndrome has been redefined so that there should be some pain that you can reproduce with your digital rectal examination in one of the muscle groups. If in fact there is no pain when you're doing your rectal examination, and the pain is reported by the patient to be recurrent but lasts 20 minutes or less, then we call it proctalgia fugax. Now I can tell you that what happens commonly in a physician's office, and I would bet in a PA's office, is that patients come in complaining of this complex of symptoms, and the provider doesn't know what's going on. They don't even know about these two syndromes, and they don't know what to do about them if they knew about them. With proctalgia fugax, it usually goes away. And usually when you ask the patient, how bad is this pain, they say, oh, you know, 3 to 5 out of 10. But it always goes away. But it really gets my attention. Always goes away. Gets my attention. If in fact it always goes away, and if in fact the physical exam is completely normal, there probably is not any treatment that's necessary. Most of the literature says no treatment is necessary. I have seen this syndrome. Okay, so the pain in both of these syndromes commonly wakes the patient up at night. It's seen equally in both sexes, and it is more common on a night after the patient has had sexual intercourse. And no one has explained why that might be. We don't have a clue why that is. It also seems to be correlated in some patients. In some studies, especially proctalgia fugax, seems to be correlated in some way with stress. It might be a physiologic response to stress. I have seen this present where the patient woke up at 2 o'clock in the morning with a rectal pain. So they got out of bed to try to figure out what was going on, sort of examined themselves, couldn't find anything wrong, tried to have a bowel movement, nothing happened. The pain started as about a 2, and over a period of a few minutes, rapidly accelerated to 10, and then 11, and then 12 out of 10. The most severe pain the patient ever had. And before woke their wife up and said, I don't know what's going on, I think you need to get me to the hospital. The pain was so scary that woke the wife up. But as she was trying to get oriented, trying to figure out what to do, the patient faints. Has vasovagal complex and faints. Fainting in face of severe pain is not terribly uncommon. He passes out, and when he wakes up, she's now on the phone calling the ambulance. When he wakes up, the pain's gone, completely gone, just asymptomatic. And in fact, had that same series of events 2 or 3 times. So this was a patient who was experiencing this in a severe form, and we started looking for ways to treat it. We started with something that we knew that this was a muscle spasm. We started with things that might relax muscle, and we started with nitroglycerin, and all that did was give him a headache, and in addition to the pain he had in his rectum, and so that wasn't very satisfactory. We finally found Levsin, which is a drug. Have you had irritable bowel syndrome lecture yet? Levsin homocysteine is a is a drug that causes relaxation of smooth muscle and is commonly used in irritable bowel syndrome. And what we found was that when we treat his proctalgia fugax with that, it goes away in minutes. It comes in two forms. One is sublingual, which makes some sense. Which makes some sense in how it would work, because it gets into the bloodstream pretty quickly if you use it sublingually. It also comes in a tablet. It turns out that it works equally well in this patient. Dr. Latassi tells me that she doesn't believe that if you swallow this, that it could be effective in 5 minutes. But the patient says that it goes away within 5 minutes, regardless of how you take it. But this is a very, very uncommon presentation of proctalgia fugax. By definition, it goes away in 20 minutes. This guy couldn't stand it for 20 minutes, he'd pass out. Okay, so to try to figure out what we're doing on the rectal examination, we have to sort of review the anatomy a little bit. It's all about inspection and a digital exam. So this is just a picture primarily for you to study on your own at home. It sort of shows you where the external hemorrhoidal complexes are down close and the internal hemorrhoidal complexes up higher. These little finger-like projections are where the rectum ends and the anus begins. The anal canal is about 2 to 4 centimeters in length. My index finger is 6 centimeters if I measure from here to the web to this. So that's about 6 inches. So I should be able to examine the entire anal canal with my stubby little fingers. And you should be able to as well. We do the digital rectal examination to look for masses. We used to also say we did the digital rectal examination to feel the prostate, but that now is under some dispute as to whether or not we do a prostate exam. Many male patients will want you to make sure you do that as well, but many say I'd just as soon not. Thank you very much. Okay, so let's go back. So the two muscle groups that we're really concerned about when we're talking about the anorectal region are the external sphincter and the internal sphincter. The external sphincter, the internal sphincter is internal because it's inside the external muscles. The internal sphincter keeps the anus closed. It's always contracted, and it keeps the anus closed so that we don't, so that the human being doesn't lose the rectal contents if they're there, so that you don't expel gas, so that you don't expel feces until you're ready to. It remains contracted. So the internal sphincter is an involuntary, always constricted, sympathetically controlled muscle. The external sphincter is innervated and is also in, it's an odd muscle, but it's also in a state of continuous contraction, but can be both relaxed and further constricted voluntarily. So the external sphincter is under voluntary control. The internal sphincter is an involuntary muscle. That's really about all you need to know about those muscles. Any questions about that? Probably studied that in anatomy already, huh? Not so much? Yeah? Maybe? Can't remember. Long time ago. Okay, so hemorrhoids come in two varieties, external and internal. The external hemorrhoids come from that complex down close to the opening of the anus. external hemorrhoidal complex. So these hemorrhoidal complexes are veins and connective tissue that are surrounding these veins. And the external hemorrhoids are right down close to the anal verge, and the internal hemorrhoids are up at about the dentate line. So here's another cartoon of external and internal hemorrhoids. The external hemorrhoids you can usually see or feel quickly because they arise so close to the anal verge that they commonly are coming out of the anal verge. And then the internal hemorrhoids may or may not come out. Hemorrhoids present primarily with itching, sometimes with pain, and commonly with the patient telling you they feel something in their anus, but they don't know what it is, and it doesn't hurt when they touch it. Makes it difficult for them to clean themselves after a bowel movement. Here's a picture of an external hemorrhoid that is not thrombosed. This is not painful. You wouldn't know whether it's thrombosed or not unless you touched it. What is a thrombosed hemorrhoid? A thrombosed hemorrhoid is a hemorrhoid that has a blood clot in it, and the blood clot has set up an inflammatory response so that the thrombosed hemorrhoid is really painful. Here are just some more cartoons of hemorrhoids and how they might look visually. So they are vascular and connective tissue, and they're dilated veins. Now, the thing to remember, this kind of thing might be on a pants exam. Superior hemorrhoids, or internal hemorrhoids, those are further up. The internal ones, the ones that are further up around the dentate line, are in the venous circulation tied to the portal venous circulation. And the external ones are tied to the systemic circulation. And the way hemorrhoids generally occur is that something has caused increased intra-abdominal pressure, or something has caused intravenous pressure, either in the portal system or the systemic system. You have a clear idea in your head how the portal system and the systemic system of veins differs? Got some idea? Think of portal vein system as dealing with liver disease, and think of systemic venous system dealing with heart and lung disease, and then that pretty much clears it up. So the internal ones are portal, the external ones are systemic. All right, risk factors. So I just told you what the risk factors are. They're anything that increases intra-abdominal pressure. Chronic constipation, the pressure is increased there because people strain, right? Pregnancy causes increased intra-abdominal pressure because there's a big mass sitting in the abdominal cavity that's pushing down. Ascites, generally there is water pushing down, water free in the peritoneal cavity, but also ascites is generally caused by either increased portal pressure or increased systemic pressure in the venous system. Obesity, heavy lifting done inappropriately, primarily because of straining, and then space-occupying lesions like tumors in the pelvis. These are just things that are risk factors, they're not causative. So when you have increased portal hypertension leading to hemorrhoids, you worry about cirrhosis, and you worry about other liver diseases. With systemic venous pressure increases, you worry about heart failure and lung diseases leading to right heart failure. So what does this mean? It means if the patient presents to you with the finding that they have something in the anal canal, you do an exam, you find some hemorrhoids that aren't thrombosed, there's really nothing emergent going on here. The question you need to begin to ask yourself is, what's causing this? Most of the time, it's sort of a benign process. It doesn't mean that they've got left ventricular heart failure. It doesn't really mean that they have cirrhosis. But you have to begin to think pathophysiologically because you don't want to miss something. Now, in old people, they're really common for probably a variety of reasons. People who are old have left ventricles that don't work quite as well. They have lungs that don't work quite as well. They have, they're usually a little heavier, not always, but they have a tendency to. The American male gains a pound a year after age 30. So, and most of that goes right on the anterior abdominal wall. So at age 60, the average American male has 30 pounds of weight sitting on their anterior abdominal wall. Pediatric considerations, it's uncommon. Hemorrhoids are uncommon in infants and children. So if you see hemorrhoids in an infant or a child, you got to start asking questions. You got to look for underlying causes. Bring this to the attention of the pediatrician. Think to yourself, what in the world is causing this? Now it turns out that constipation isn't that uncommon, especially in male children around the age of 2. And they strain, and so it's not terribly uncommon there. Pregnancy considerations, it's really common in pregnancy for the woman to develop hemorrhoids. They usually are asymptomatic, and they usually go away after delivery. So it doesn't mean that this pregnant woman has heart failure or liver disease. It means that she's had a mass in her abdomen for 9 months, and this will go away after delivery, almost always. Okay, so what do we do? Well, there again, the treatment of hemorrhoids is pretty common sense stuff. You want to try to eliminate the cause, but if you don't find increased portal hypertension and you don't find systemic venous hypertension, then you have to say, well, how do we treat this locally? One is to make sure that bowel movements are easier. If they've been constipated and straining a lot, you got to relieve that. So you do that with stool softeners, you do that with increased water intake, and the whole armamentarium of things you can do. If there's pain and a little inflammation, you can use sitz baths. You just sit down in hot water and use hot sitz baths 15 minutes a day or twice a day. You can increase fiber in their diet, and then you can use steroids. What do steroids do? Steroids decrease inflammation, and if there's any discomfort to these things, either itching or pain, they're inflamed. And so steroid creams can help. Steroid creams over the counter will work most of the time. And then there are steroid suppositories you can use, Anusol suppositories, which have a steroid in them, and you can use those twice a day. Even though the literature is pretty soft on how well steroids work, how well these suppositories work, I don't know anyone that doesn't use them. So if a patient has hemorrhoids and they're symptomatic, even if they're not symptomatic, I see clinicians use them, and I use them personally pretty frequently, just to try to decrease the size of the hemorrhoids. Any questions about treatment? It's kind of common sense treatment, just knowing that steroids are used, either the creams or the suppositories. Now, if the steroids won't work and they're just driving the person crazy, you ligate them. I've never done this personally. I think I probably intentionally stayed out of the business of ligating hemorrhoids, since you have a choice of things you do. But there's a little gizmo. Isn't there a little gizmo you use? It looks like a pen or something. There's a gizmo that you use. It's a little tool, and it has a rubber band on the end of it. And you work the hemorrhoid into this gizmo and hit the switch, and the rubber band pops around it. It's a real high-tech kind of digital thing. No, digital thing maybe. And it just ligates the base of the hemorrhoid, cuts off its blood supply, and you just leave it on there, and then in a few days it falls off. I think that's why I didn't get into the treatment of ligation. I don't want to be associated with that for some reason. I send those all to my surgery buddies and let them be responsible for that. It just falls off. If they remain symptomatic and ligation doesn't work, then they can have a hemorrhoidectomy, which is also never done by an internist. Now, the thrombosed hemorrhoid is sort of a semi-emergent situation. These people are so uncomfortable that they're gonna demand that something be done pretty quickly. So, what I do, I've only seen 3 thrombosed hemorrhoids in my 35-year career. So, but I've gotten a surgeon involved that day, and they have a variety of tricks up their sleeves that they can use. They never tell us what they are, so that we won't do them and not send them to them, so I don't know what they are, but they take care of them. Thrombosed hemorrhoid. It's big, it's tender, it's inflamed, it has a blood clot in it. Now, I saw one thrombosed hemorrhoid taken care of in the office. I was in an office where I shared space with the general surgeon, and he went in and took a knife to it right there in the office and expressed the blood clot and then ligated the hemorrhoid. It was amazing, and it worked nicely. So, but again, I don't use knives. I think they're dangerous. Okay. Any questions about hemorrhoids? So the second is anal fissure. An anal fissure is just a break in the anal mucosa. It's just a tear. It's a tear in the anal mucosa. It's nothing more than that. It's just something traumatically has caused the anal mucosa to tear apart. And you see a small tear. You see it on visual examination of the rectum, of the anus, and it's painful. These people are generally in a lot of pain. They're longitudinal tears, which makes anatomic sense. They're classified for arbitrarily chosen reasons. Less than 6 weeks, if it's been there less than 6 weeks, it's an acute fissure. If it's greater than 6 weeks, it's a chronic fissure, but it's not very important. Epidemiology. It affects all ages. It's common in infants from 2 to 24 months. I don't know what this says. Elderly, less common. It's less common in older people. Common in children, babies. Okay, so you're sort of back to the same things that cause this, that cause hemorrhage. So high pressure within the anal canal, usually as a result of straining at hard stool. That leads to ischemia of the tissue and then a resulting splitting of the anal mucosa. Then once it tears, it sets up inflammation and spasm, and that inflammation and spasm is what's causing the pain. You've got a sphincter that's sitting there trying to keep that anus closed, and it's always contracted. So now you've got an inflamed spot where the muscle is contracting around it, and so this This is a really painful situation generally. Risk factors, passage of hard stools. So people who are chronically constipated are at high risk of this. High resting pressures, again, just like in hemorrhoids. Trauma, inflammatory bowel disease can do this, especially Crohn's. Crohn's disease can present with lesions, these inflammatory ulcerated lesions in the anus, and they will rapidly, they commonly turn into an anal fissure. So Crohn's disease is something you have to worry about if someone has recurrent anal fissures. Or if they present with a story like inflammatory bowel disease. How does inflammatory bowel disease present? Have you had inflammatory bowel disease yet? No? I'll just clear it up now, you can skip that lecture. Inflammatory bowel disease, either small bowel or large bowel. Ulcerative colitis is when it occurs in the colon, but Crohn's disease is in the small intestine. Crohn's disease skips around and causes lesions here and there, and it can cause lesions in the anus. So inflammatory bowel disease is someone who's had lots of abdominal pain and lots of diarrhea. These are people who present with abdominal pain, diarrhea. It's sometimes difficult to tell inflammatory bowel disease from irritable bowel disease because irritable bowel disease causes pain and causes diarrhea or constipation, so it's hard to tell those two apart. You have to do some diagnostic testing to find them apart. But when you find a recurrent anal fissure, especially in someone who has recurrent abdominal pain, you have to kind of wonder about Crohn's disease. All right. Now there are some other infections that are listed here that are really uncommon. Chlamydia, syphilis, herpes, tuberculosis, that can be associated with anal fissures, but these are really uncommon. Unless the history leads you down one of those roads, that's not a very common diagnostic category. Now, like all other things that cause chronic inflammation and chronic infections, you have to worry about that group of people who are immune compromised. Some people are born immune compromised, right, with combined immune deficiency syndrome. Other people develop something that makes them immune compromised. And there are a long list of immune compromised patients. People who have uncontrolled diabetes are immune compromised. You know how uncontrolled diabetes makes you immune compromised? If you bathe white blood cells, regardless of whether they're polys or lymphocytes, if you bathe them in a hyperglycemic environment, they won't work right. If you take polymorphonuclear leukocytes out of a patient's bloodstream that has a blood sugar of around 300 all the time, and challenge them in a petri dish with bacteria, they will not phagocytize the bacteria. The polys won't work. And the lymphocytes will not hone in on antigens to which they're already programmed. So chronic diabetics who don't have controlled blood sugar are immune compromised. And then we also know people with other chronic illnesses like HIV are immune compromised. So you always kind of have to keep in the back of your mind, is this an immune compromised person? So that's why they're commonly associated with inflammatory bowel disease, Crohn's disease, tuberculosis, leukemia, and HIV. That's just because they're immune compromised. Okay, we already talked about this. They come in saying they have pain on defecation. They commonly come in and say, I've had some intermittent bleeding. I see the blood on the toilet paper and I see the blood on my underwear. When they have a When they pass a stool, they feel as if something is tearing, because it is. And they have pain produced by anal spasm. So all this kind of makes sense, you know. If you can figure out that there's a tear in the anal canal, then all this other stuff makes sense, right? None of this is surprising. Now, this is another picture that didn't show up well in this, but you can study it on your own. You may have. It's just, there's just a picture there below the dentate line of a fissure. I don't know how to make this, get this whole thing to show up. It showed up on my computer, so I think if you go through this on your computer, you'll see. I don't know what's showing up here. It's just a tear. These pictures aren't doing well. This is just another slide. Shows some fissures. So treatment. You got to avoid the repeated tearing. So softening the stools, getting rid of constipation. You need to try to keep it clean. One of the problems with anal fissures is now you have exposed tissue, and every time you pass a bowel movement, you're washing it in bacteria, so it's a problem. High fiber diet, stool softeners will help with the constipation and the ease of stool. And then there's this whole business of nitrates, calcium channel blockers, and botulinum toxin to try to keep the anus from spasming. I've never used any of these for anal fissure in 35 years. I've never taken care of an anal fissure that didn't heal on its own by softening the stool and sitz baths and cleaning them. The nitroglycerin is generally an ointment. It's not very well tolerated because nitroglycerin ointment causes severe headache. We used to use, when I was a resident, there was a nitroglycerin ointment that we would put on people's skin when they came in with angina. And the first time I was in the ICU and admitted the patient with severe angina, I decided to use this. And the genius that I am, I took the tube and squirted it in my hand, did that, and then rubbed it on the patient's chest. And in about 45 seconds, I had the worst headache I had ever had in my entire, I had a headache so bad, I had to leave the room. This is really stupid. He's going to work on dilating his veins, he's probably going to work on dilating mine. I'm rubbing my hands in it. Well, we use this nitroglycerin, or someone uses this nitroglycerin right on the anal fissure. Calcium channel blockers are taken as pills to try to keep the spasm down in the anal canal. And then botulinum toxin is used as an injection. I suppose in people for whom you can't get the fissure to heal and the pain is chronic. Again, I don't inject botulinum toxin in anyone. Seems like a real bad idea to me. Here, let me inject some stuff that usually kills people. I don't know. Sometimes it doesn't quite work. Okay, so that was fissure. Now we're going to talk about fistula. So a fistula is where a crypt, an anal, what we've got in the anal canal, that 2 to 4 centimeter anatomic region, is back up among those muscles and connective tissue. We have anal glands, okay? Anal glands secrete stuff, okay? And they secrete it into what is called anal crypts. And the anal crypts are secreting it into anal ducts. And the anal ducts empty this stuff into the anal canal. And so anywhere along that line, from the anal duct to the crypt to the anal gland to the crypt to the duct, can become obstructed. Can become obstructed from what the textbooks call debris. And once they become obstructed with debris, they can then become infected. When they become infected and there's an obstruction to the outflow of this stuff, now you have pus under pressure. And pus under pressure looks for a way out. And so you can develop these fistulas. But what you've got is pus under pressure looking for a way out. And it causes a fistula tract somewhere along the tissues between that duct, or that anal duct, and either the anal canal or the external anatomy, right? So this thing could cause a fistula that goes out through the tissues and shows up out on the buttocks, or it can cause an anal fistula down into the anal canal. Does that make sense to everybody? It all starts in this, what's now sort of called the anal sac. That's the duct and the crypt, part of the gland, the crypt and the duct. It's an anal sac. There are a group of surgeons who are rectoanal surgeons. They specialize in the rectum and anus, and they can do a sacectomy. I mean, it's a pretty tedious, small microsurgery, but they can go in and dissect these things out that are obstructed. All right, I think that's pretty straightforward. So they can be, like I just said, over here on the right side. Is there a pointer?
There's a stick.
On this thing?
No, that one doesn't.
Okay.
Show
Well, you can just see an anal fistula that can come out through the buttocks and to the outside world, or it can come out into the anal canal. You again, one that empties into the anal canal is difficult to diagnose. Patient may complain of pain, of a foul-smelling stool. I don't know of any nicely smelling stools, but the stool really smells different from what they're used to, if there's pus in it sometimes. And then if it comes to the outside world, they know something's wrong because they've got a sore on their skin and they're leaking pus out of it. Okay. Now, I put this in here because I suppose, I don't know, if they put this on pants, we ought to sue them. But there's all this classification of fistula. I would ignore this if I were you, because I can't imagine, in our situation as clinicians, we care about this. But the way they classify them is where this fistula tract is in relationship to the internal and external sphincter. Okay, transsphincteric, suprasphincteric, extrasphincteric. Oh my goodness. I won't test you on this, and I doubt if anyone else will either, but it sort of tells you, sort of anatomically, how these surgeons look at it. So if the patient comes in with a fistula and we don't know exactly where it is, we can do 4 exams. We can do ultrasound, we can do a CT, we can do an MRI, or we can do a fistulogram. And a fistulogram is we find the fistula tract and inject, those radiology people, they put a small catheter in the fistula tract and inject a radio opaque dye and then figure out where the tract is. And then they can either do an MRI or a CT scan and figure out exactly where it is. Because commonly these have to they have to undergo surgery. We've already talked about the pathophysiology. Risk factors, again, are inflammatory bowel disease, for obvious reasons, pelvic radiation, Pelvic radiation makes some sense because if you radiate the pelvis for something like pelvic cancer, say cervical carcinoma or uterine carcinoma, you're radiating all the tissues in the pelvis. So you're creating pelvic tissue that's not as healthy as it used to be. Perianal trauma, carcinomas in the pelvis, abscess formation due to things outside the pelvis, appendicitis, salpingitis, and diverticulitis. Okay, so that makes some sense. If you have a diverticulum that is in this rectosigmoid colon and it bursts and dumps pus out in the pelvis, now you can develop an abscess in there and you can develop a fistula that comes to the surface. So that would be a recto fistula, not just an anal fistula, but a rectal fistula. Make sense? Again, you have to worry about the immunocompromised state in anyone who presents with a fistula. You have to ask yourself, is this someone whose immune system is healthy, or is this someone whose immune system is compromised? So, on physical examination, you're looking for redness of the skin around the perianal area. And you've got two other problems you have to worry about. You have to worry about a rectovaginal fistula, where the fistula tract has gone from the rectum to the vagina. And this presents with the unusual presentation of the woman complaining of pus coming out of her vagina, stool coming out of her vagina, and flatus coming out of her vagina. Because there's now a fistula tract directly from the rectum into the vaginal or vaginal canal. Not common, but I have seen it twice in 35 years. And then there's the rectovesical fistula. So the fistula tract goes from the rectum to the bladder. These people present with two things. They present with frequent UTIs. Usually they would present with an inflammatory pelvic presentation, but sometimes people just put up with it. The fistula tract gets made and then sort of gets healed in, if you will. And now they're just passing bacteria chronically between the rectum and the bladder. And so they keep presenting with recurrent UTIs. They get a little better when you put them on antibiotics, recur. They get a little better, they recur. So recurrent UTIs need to be evaluated. You need to figure out what in the world's causing this. They can also present. I had one patient who came in and said, I know this sounds really crazy. It was a male. He said, I know this sounds really crazy, but I pass gas when I'm peeing. And that would make sense if they have a fistula between the rectum and the bladder. So here are the four things you would use. You use ultrasound, you use the fistulogram, CT, and MRI to try to figure out where this tract is and how we're going to approach it. It's all figuring out how you're going to approach it. A fistula will always include the input of a surgeon, because someone who doesn't use knives isn't going to fix this. This is a surgical illness. All right. And then there are anorectal abscesses. This is the same pathophysiology as an anorectal fistula. Something obstructs that anal duct, or that anal crypt, or the gland. There's an obstruction in that gland to crypt to duct phenomenon. And instead of the pus finding a way out through a fistula tract, it just stays in there and creates an abscess. An abscess is pus under pressure. They usually present with fever, high white blood cell count, labs consistent with an infection. Most of these are perianal. You can usually see evidence of them on exam. There's redness and tenderness, and you can usually see it because they're, these are usually perianal. Sometimes they're perirectal, but they're pretty close to the surface. And there's pus in there. It's pushing out. You can usually see tenderness somewhere around there. Synonyms: perianal abscess, perirectal abscess. These are synonyms. I went to check-in rounds one morning to see what the intern had done the night before, and the intern showed up sweaty, looking acutely ill. I said, "What in the world is wrong with you?" He said, I don't know, but I got something bad wrong down around my anus. He went ahead and presented the patients he had admitted. He admitted 2 or 3 people and worked them up and was sick all night. And so I said, "You got to go to the ER." And he had a huge perirectal abscess. And I didn't take care of him. The surgeons took care of him. I don't know how long he had been mildly symptomatic before he got acutely ill that night. Required surgical drainage. Just a little story that says it can happen to any of us. The diagnosis, of course, there's pain. So, all these things I'm presenting today can present with rectal pain, or pain down there. They're constipated because they don't want to have a bowel movement because it hurts like the dickens. They have fever, they have chills, they have a spontaneously foul-smelling discharge. So you just inspect, you palpate, then of course, because it's an abscess or an infection, you would culture it to see what the primary bacteria is. It's usually going to be E. coli and/or anaerobic Bacteroides fragilis. May require endoscopy, maybe fistulography, but it's going to require a surgical consult. Pus under pressure must be drained. It's a rule. Pus under pressure must be drained. Fecal impaction, it is what it says it is. This is a rectum so full of feces that the patient can't get it out. And this can be caused by a variety of things. Patients sometimes present with the history that they haven't had a bowel movement for 2 weeks, 3 weeks, or they sometimes present with abdominal pain and diarrhea. And you can be really fooled by the patient who presents with abdominal pain and diarrhea, and they are embarrassed that they haven't had a bowel movement, so they don't tell you that. They're impacted and obstructed, and what they're doing is leaking liquid around the outside of that impaction. They're calling it diarrhea because it's liquid, but what they really are is constipated. Now, there are some metabolic things that can do this. Hypercalcemia, so the patient with hyperparathyroidism can present with an infection. Hypermagnesemia is really uncommon. Hypermagnesemia almost has to be 2 things. It almost has to be someone with renal insufficiency who is taking magnesium for some reason. Narcotics can do this, and narcotics are really, really common as a cause for fecal impaction. Narcotics cause lazy bowel, and constipation is the most common side effect of using chronic narcotic analgesics. People sometimes get it just because they're not up and around. Being mobile somehow stimulates the GI tract. So this is more commonly seen in elderly It's not too uncommon in rest homes for patients who just lie in bed or sit in a wheelchair all day. They're also commonly on pain medication for chronic pain, and so fecal impaction is not uncommon in that age group. We already talked about that. The diagnosis is made by rectal exam. You do a rectal examination and your digit just goes into a wall of feces. You can also see it on a plain x-ray of the pelvis generally, or on a CT scan you can see it without question. So the treatment is disimpaction. I was making rounds with a third-year student on the surgery service, and the man was complaining of abdominal pain, blah, 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 blah. The chief surgery resident who was making rounds with us did a rectal exam and said, you have a rectal impaction, and Dr. Bonata will get that out of there as soon as rounds are over. Not a very fun thing to do, but I mean, you got to get that out of there, and you can't get it out. Usually, you can't get it out any way besides digging it out with your finger. It's just, it's not why you signed up for PA school. That's one of the things that might come up, so to speak. So the way you treat it is get rid of the impaction and then try to change whatever caused it. Try to decrease these narcotic analgesics. Try to increase the fluid intake. Try to increase the fiber, try to do the things we would normally do to increase bowel movements. And then an occasional patient will require surgery, but it's really uncommon. And then lastly, we'll finish up with neoplasms. Now, neoplasms of the anus are rare. These are very rare. They're located either externally on the anal verge or in the anal canal. And one of the reasons we do a digital examination is to feel a rectal mass. And so in my world, when I see a new patient, an adult patient, male or female, and it's a new patient to my practice, and I'm doing what we call a normal or complete screening physical examination. It always includes a rectal exam. And the primary reason for doing that are two. One is to look for masses in the anal canal, and the second is to look for blood that is not obvious to the patient with bowel movements, but to do a guaiac test to make sure they don't have some minuscule blood in their stool. Okay. Now, risk factors are anogenital warts. The human papillomavirus, which we normally think of as it is a sexually transmitted virus. We think of it generally as warts, condyloma acuminatum of the vaginal wall, of the external labia, on the shaft of the penis, and can present in people who have been having anal intercourse on the anal verge. Now, there's a syndrome in which condyloma acuminata, which is the genital wart, can be present so long that it transforms into squamous cell carcinoma. So this is a precancerous lesion. We know that human papillomavirus is a precancerous lesion on the cervix, and we know that it's a precancerous lesion on the penis. It's also a precancerous lesion on the anal verge. I once was sent a patient from Southwest Oklahoma